Thank you, Roxana. Thank you, everybody. So maybe you should know we've been doing IVBT for almost 25 years, maybe even more than that, because we started the trials. These are my disclosures, nothing relevant to this presentation. But let's start with the case presentation, because I think that really will illustrate where is the issues, or what are the issues. So this is a 68-year-old male with all the risk factors. He had also remote CABG, lima-2 LAD, SVG occluded. That was done in Germany. Then he had multiple PCI. Most recent one was in October 2023 to the ostial LCX for ISR. He had total of 16 stents. And he returns with class 3 typical angina and dyspnea. Again, this is all the calendar of the procedure that he had. He almost had any procedure you can imagine with DES and also with DCB. And now he presented to us in October 2023 with angina. And he was actually told, just take medical therapy. Enough is enough. We're not going to put any more DES. We're not going to put any more DCB. And this is the number of drugs that he was on it. He couldn't tolerate ranolazine, so he was sent for us for treatment of recurrent angina. And this is the angiogram. There's nothing unique on the RCA. The lima to the LAD is open. But this is the problem. You see here a very long stented full metal jacket through the entire circumflex artery. And what we are doing here, we ballooned it because we couldn't get imaging before ballooning that with a 2.5 balloon at 3 separate sites. And then we image with OCT, and you can see here that there is tissue, and there is also an area of under expansion. And here is another OCT pullback after dilatation with more aggressive balloon, including open NC. And I can show you also the IVUS pullback. Again, you see the multiple layers of stents from distal to proximal. So some of them seems to be better expanded. But if you go, as you go all the way to the ostium, there was a calcified nodule there. And you see here coming the tissue, the underexpanded stent. And this, guys, is not going to be help to put another layer of stents, another DCB. And that's why he was referred to brachytherapy. So this is the sizing by IVUS that we have done. And when you look at all those classification that was mentioned before, you can see that many of those by which type can accommodate VBT if you have it. But if you don't have it, don't be shy to send it to, if you're in New York, to Dr. Sharma. If you're in Washington, send it to us. But there are centers that are doing it, and it is important. And again, at the end of the day, whatever you look here, VBT or IVBT is a very good option. So the plan with him was, again, to do the imaging, to do high pressure balloon. We use open NC, laser, or IVL. The last thing that we wanted to put is another DES. I think that's the key issue. It's not going to help. When DES failed before, there is no point to do it. So we basically did emerge NC 3015, and then we did open NC. Primarily on the proximal. It was very hard to open it because, again, if it's a mechanical issue, it's not going to be opened by itself. And then if you want to see how the brachytherapy system looks, this is what used to be called the Novo system. It's a transfer device that contains seeds in a length of about either 40 or 60 millimeter. It's connected to a catheter. And this is one of the markers. So you don't see the actual seeds, but you see the markers. And in this case, we had to go with one long application, 40 millimeter catheter, 23 gray. It takes about nearly 6 minutes to dwell the radiation therapy here. And that's the results post-procedure. Now, you ask me if that's going to hold. Most likely it would. Forever, probably not. But what do we know? We know that if you look on cutting balloon versus DES or VBT, then cutting balloon is not going to make the job. DES is an option, especially if it's in the first or second layer. And you can see they're almost on top of each other. And this is from our own data. Now, what happens if you have recurrent in-stent restenosis after failed brachytherapy? If you put a drug-eluting stent, that's the worst thing that you can do because the vessel has not been healed and it can cause stent thrombosis. So if the patient had failed brachytherapy, which does happen, then the best option is to do another brachytherapy. And that's how you do it. You separate at least 9 months between the two applications, and you probably push the patient to another 2-3 years free of angina, which is a lot for those patients. If you look on any other options for failed brachytherapy compared to balloon, again, the repeat brachytherapy would be the best. Now, this is a paper that comes from Sharma Group, published in Circ Intervention. Did show, again, that if you compare brachytherapy versus control, and control was all of the above, was balloon, DES, DCB was not available at the time, but you can see the curves are completely in favor of brachytherapy. So why do you have to wait for second, third time? You can go for the first time or for the last time. So in my opinion and my experience, IVBT is the most effective therapy that is existing today for in-stent restenosis if you overcome the mechanical issue. It is a safe, it does not require additional layer of stenting, and it doesn't require prolonged DAPT. This is a misnomer that people think that if you do brachytherapy, you have to give DAPT forever, but it's not true. So in summary, IVBT is the first and the last option for treatment of ISR. It is a viable option for failed DES, DCB, and also VBT. Thank you very much, and I hope to see everyone CRT 2025.